as was announced at the very beginning, I was really active in Oregon in developing and working on, and actually the implementation of their overall healthcare system transformation efforts. And just as a way of reference, those efforts were largely led by the healthcare community, like the healthcare providers, the insurance companies, the hospital systems. And so that's the background and the experience that I have in coming here. But the goal isn't to replicate what was done in Oregon. Rather, the goal is to look at, well, what does Hawaii want to do when it comes to health transformation efforts and go leading in new directions? Where do we want to go as a community? And one of the most striking things that has occurred as I've gone out and done the listening, et cetera, that is in stark contrast to my Oregon experience, is that the lead off to that conversation when we're talking about health transformation and where it is that we want to go, it's leading with the outcome that we want, and that's healthy communities and healthy families. That's the lead. That's the starting place. And then it's not about, well, we need to transform the healthcare delivery system and make sure that it's sustainable financially. Rather, it's about healthy communities and healthy families. Immediately, there's a recognition that in order to have healthy communities and healthy families, that you really need to focus on what we call the so-called social determinants of health. What that means is that it's beyond the clinic walls. We know that only 10 to 20% of our health, right, of our actual health is determined by our doctor's visits, our medications, or what happens within the clinic walls. 80 to 90% of it is actually based on where we work, what work we do, what's our education levels, what's our where we live, what's our context, what's our environment. It's our genetic code, it's our lifestyle, it's our lifestyle behaviors. All of those things are the actual social determinants of health. We also know that where you live, your zip code, is more influential on your health than your genetic code. So when we're talking about if you really want to make improvements to the overall health and create healthy families and healthy communities, you have to focus on your education and the education system. You have to focus on housing, because housing and health are intricately linked. You have to focus on the environment that's around you and making sure that you have environmental health, you have clean drinking water, et cetera. So those are some of the basics of what it takes to develop to have or nurture healthy families and healthy communities. If you note in there, I didn't talk about the doctor's visits and the health systems, et cetera. But yet, we also need to transform those systems as well. Because even though we recognize that 80 to 90% of the influences of our overall health are outside of that clinic wall, 80 to 90% of the dollars spent are actually within the healthcare delivery system itself. So somehow we have to realign those financial incentives when we're thinking about the healthcare delivery system, so that the healthcare delivery system is as interested in the social determinants of health as they are in the most recent medications that are available. So that we have to create those incentives so that those systems are working together. That is not an easy thing to do, because that's not how our financial system is set up for the healthcare delivery system. How our healthcare delivery system is set up is the sicker you are, the more money flows into the healthcare delivery system. The more money that flows into the healthcare system does not come about the healthier you are, right? People get paid, hospitals get paid for the beds, for people who are occupying beds. And yet, if I were to take a poll, who wants to go to the hospital and spend their weekends there? We don't have very many hands going up in the audience, and yet so we know that there's not the financial alignment between those two things about what we want and how it is that we pay for those services. And guess what? We get what we pay for, right? We get a system that is paying for and is aligned with essentially sick care, not health care. So that's a really tall order. So how is it that we can go about changing the health care delivery system? Well, we need to start thinking more upstream, what we call upstream. And that's thinking about population health. That's thinking about, okay, what does it take to keep a group of people healthy? How do we pay for that differently so that we can actually start what's called bending the cost curve? Instead of having healthcare costs go up like this, that instead of going up at that angle, okay, maybe they just go up at that angle instead. So that we can start taking those dollars and really investing in our education system, in our housing, the other things that really make a difference in creating healthy communities and healthy families. It's also about creating a more efficient and effective healthcare delivery system. And that means having the various healthcare providers being able to work together, to be able to know so that they don't have to order duplicative tests when that's not needed, that they know that someone is going to someone's home and providing care and that they get those results, so that those people who actually need that level of support are getting it, and those people who don't need that level of support are also getting the basic preventative care that enables them to stay healthy. The final piece that I will add to this, and this is part of the overall transformation efforts, is that none of these efforts in creating healthy communities and healthy families are done out of the context of the overall what we might want to think about as health disparities or health equity. In other words, some people need more kinds of care, just given their background, given their race or ethnicity, given their economic status. So what they need, or for example, if they're disabled, their care is going to look different and their needs are going to look different because they're different and their context is different. And so if you don't take into consideration that overall lens of health equity, for race and ethnicity, for geography, for economic conditions, then you're not going to do as well. So what is it that, what's the focus then how do you take these really lofty, big ideas, how do you take them and you make them a reality within the Medicaid program? And that's where I want to talk a little bit more, sort of taking it from this really high level vision of creating healthy families and healthy communities and taking it down to, okay, so what specifically are we going to start working on within not just the Medicaid program, but also with the Department of Education, with the Department of Health, with public safety, with all the various state agencies, as well as other stakeholder groups, insurance companies, sort of the hospitals, healthcare associations. So how can we work together, and what is it that we're working on together? Well, one of the first things that we're working on that's taken up a tremendous amount of time in the first 6-7 months now since I've started is making sure that people have access to health insurance, that they have continued access to health insurance coverage. And what I'm referencing is the fact that the Hawaii Health Connector is no longer essentially functioning, that it's in the process of being wound down, and the state is needing to pick up those functions. And so DHS is part of that effort of trying to make sure that the functions for outreach and the contact center, that we still have people out there in the communities assisting in getting access to health insurance. That has taken up a lot of time because that was a big, pretty dramatic change from when I started, July 1. That effort was started in May, so it was just a couple months before I started. And that's taken up quite a bit of time. But besides that, once we have that sort of under control and we make it through this open enrollment, which ends this coming Saturday. So if you know people who are uninsured or who were insured through the Hawaii Health Connector and they've not taken action yet, this is the week. This is the very important week, because if they don't take action and they don't sign up, then they could be uninsured and they could face pretty stiff financial penalties this year for not signing up for health insurance. So that's my little plug for those of you who work with people who are uninsured. If we can get the word out, continue to get the word out, that's going to be really, really important. In the more the medium term, in other words, once we get through this open enrollment, our other focus for helping to get people enrolled and continue health coverage is largely around people who are dealing with transitions from one place to another place. And so in this case, what I'm talking about is, for example, if they've been in the state hospital for mental health, mental illness reasons, if they are in the prison system, and they are transitioning out. What we need to do and what we're working on is making sure that individuals have not only continuous eligibility, so that as they move out of the prisons, for example, and back into the community, that not only do they have Medicaid coverage from day one, but also they have sort of a warm handoff, so that the providers who were caring for them while they were in whatever institution, that they have connections with the provider community who's going to be now providing care for them from day one. Because we know that if we don't provide that, then individuals are more likely to wind up back on the streets and then back in those institutions. So it's an overall effort then to help address one of these social determinants of health, which is making sure that people have access to health insurance and have sort of that warm handoff from one entity to another. The other area that we're really focusing on is we have a healthcare delivery system, which I'm sure all of you recognize, that really treats the person and the community and the family as if they were separate body parts, right? So we have, it's based on, I mean, that's how our healthcare system is designed. You go to somebody who specializes in hands, somebody who specializes in cardiac, and that's fine. We need that specialization, but we also need that to be an integrated, focused effort, and we also need to make a recognition that the health is not cut off and it is not separated from your head from the rest of your body. And so what I'm talking about is the fact that within Medicaid, we have not had an adult dental benefit since 2009. The only thing that we cover for within Medicaid is extractions and emergency dental procedures. For example, if you go into the ER, et cetera, then you can be treated for the pain. And you can have your tooth extracted. We know that is not good care. We also know that if you have a condition in your mouth and you also have a cardiac issue or you're diabetic, your oral health is intricately linked to your overall health, and that those things interact with each other. So to not have that dental benefit is not providing whole person care. So we have a budget request in this time, and the governor is supporting that in his budget request, which we are very, very excited about. The other area that we're spending a lot of time on, a lot of work and a lot of time on, is in the area of behavioral health, the integration of behavioral health and physical health. So what is behavioral health? It means mental health as well as substance use. Within the Medicaid population, we know we have higher prevalence rates of both of those things, of individuals who we have more individuals with mental health issues. It doesn't have to be severe, but it could be just, depression I shouldn't say just, because this has serious ramifications for people's overall health. And we also know that there's a number of individuals who also suffer from substance use and addiction. So there's quite a bit of work that we're doing with the Department of Health, with public safety. There's several initiatives coming out of the governor's office as well. And that's also one of the, there's the issue of homelessness is like quite complex, but one thread of the issue of homelessness has to do with making sure that we have more integrated and better mental health and substance use for people who are homeless. Those two things can sometimes be quite intricately linked together. So we're doing a lot of work in that particular area as well. One of the other things that we're focusing on is, well, how do you get mental health or substance use to be treated early on so that we can actually have prevention? And that means having it take place in the primary care setting. Well, a lot of primary care providers do not feel comfortable sort of dealing with mental health or substance use diagnoses as they run into them. And because they're really fearful that if they run into somebody with severe issues, then they won't know, they don't have the expertise and they don't know how to refer out or get or obtain the specialty care that's needed. So that's also a lot of work that we're doing is, well, how can we provide better supports for primary care providers? How can we use better screening tools? How can we do some better training on some brief interventions for people with mild to moderate conditions? And then how can we create a better referral system for those individuals when they do screen and they do recognize or come across individuals who need a higher level of care? How can we create better referral systems? Part of that issue is that we have a lack of behavioral health specialists in the state, particularly on the neighbor islands. So that's a real serious concern. So we're looking at a number of different mechanisms on how we can provide better mental health care for the neighbor islands when we know that it's going to be very challenging to get enough providers, like for psychiatrists, on the neighbor islands. So we're looking at more advanced ways to do telehealth and telepsychiatry, and redoing our rules around that to allow the appropriate parameters to allow telehealth to occur and actually promote it. And also, what ways can we train and support primary care providers? And then in what ways can we train a broad cadre of healthcare providers and what we call paraprofessional healthcare providers, like community health workers, that can, you don't need necessarily a physician, doing all that care. You can also rely on community health workers who can go to people's homes and help there. Now that's going to be very familiar, and it's actually modeled after the long-term supports and services work. As many of you might be aware of, there's a real strong effort nationally, and it's also here, it's from the state I came from as well, to create those supports and services in the home, or actually to allow people to age in place for as long as possible and as long as feasible. So in Oregon, the state where I came from, where I was Medicaid director, the percent of individuals who were getting long-term care supports and services in nursing facilities versus either home or community-based services was there was 15% of the population was getting those services in nursing facilities, and then about 40% or 42% in community services like assisted living, adult foster homes, residential homes, and then the other 42% were getting it out of their home, from their home. And in Hawaii, while we're good, I think we have about 35% of our people receiving long-term supports and services. in nursing facilities, it's not as good. It's not the proportionately, we have some work, we have some room to go here. So one of the things that we're looking at is that was actually just implemented in the last couple of years is an expansion of who can receive home and community-based services. So in the last couple of years, we implemented an at-risk program so that if individuals are at risk of needing a nursing facility care, then we can authorize, and we do authorize, the provision of home and community-based supports that help enable individuals to stay in whatever setting or whatever place they want to stay for a longer period of time. This is part of an overall national effort, and so it's not just here in Hawaii, but there's a lot of financial incentives and a lot of work and effort going on to support this. The other area where we're also seeing it is within the area of what we call a transition plan. It means that individuals who are receiving supports and services within community-based settings, like assisted living, like residential homes or adult foster homes, that there are new rules that came out, I think a year and a half ago, 2 years ago, of requirements of requirements for those institutions to have greater choice, greater flexibility for the people who are living and residing there. Food choices, roommates, people can lock their doors, people can have people come and visit them, et cetera, within what's safe for those individuals. So we have a huge effort going on right now in working with all the various community-based organizations to make sure that they can comply with these rules. We have another year to make that, to complete that process, and so we're really, really quite active in doing that. One particular group that we're really focused on and working with very closely is with the developmental disabilities group. They have to do a new waiver, which is what we have to have a waiver with the federal government in order to operate our program the way that we want to operate it. And so we're working also with the Developmental Disabilities Association, or not association, administration, in order to renew that waiver. And they're looking to do the same kind of thing that would allow individuals with disabilities to live more independently as feasible within the community. To get employment, to establish stronger support networks, et cetera. And that should sound familiar to you because those are the social determinants of health, right? Work, life, social networks, those are the social determinants of health. So to the degree that we can support that, then we know that we are actually supporting the social determinants of health, which enable people to stay and be healthier. We also have a budget ask that's related to that, in that Hawaii is one of 2 states that does not have what's called a Medicaid buy-in program or Ticket to Work, and that allows individuals with disabilities to work, to have the income that would push them above what the Medicaid income limits are, but still maintain their Medicaid coverage. Many of you may go, well, if they're working, don't they have health insurance, and why would they still need Medicaid? And it's because Medicaid actually provides a broader range of services than the traditional health insurance plans, because we include those long-term supports and services. And for individuals with disabilities, they rely on them to be independent, to live independently, and oftentimes they would rely on those services to support them with their employment, et cetera. So we're looking for a budget ask also for implementing the Medicaid buy-in program. So I could go on and on. We have a lot of effort also on of working on the homeless issues, where Medicaid is one thread within that, as I mentioned, with particularly around behavioral health, et cetera. But what I would rather do is probably take a break right now, because I've done quite a bit of talking, and find out if there are questions that you would like me to address.
Does Medicare pay for care of eyes? That's why, like eyeglasses and eyes examinations and things like that.
So, unfortunately, I don't know much about Medicare and the services they provide as I do about Medicaid. Under Medicaid, we do provide vision services, but I don't know about Medicare. I apologize.
One of the issues that's currently before the legislature is caregiver training in hospitals. What I'd like to know is, do you see Medicaid having a role in providing caregiver training in the home, as well as the care that they may need once they're discharged?
Yes, actually, I think that hits on a really important point. I think, caregiving in the hospital, while I understand I understand the need for it. A lot of times, in the hospital, people are, they're coming in, and you're going through the whole thing, et cetera, and making sure that they can get this. But what's been shown to be effective is actually in keeping people out of the hospital and keeping the reduction of readmissions is actually follow-up, a day or two afterwards with the caregivers or with the person who's receiving that care for as part of that sort of discharge planning. It's actually going over that at home and answering questions and that follow-up. And so it's actually is several of the health plans already incorporate that into what they include in their sort of payment. But it definitely is something that can be paid for and accounted for as far as the training goes and reviewing the instructions within Medicaid.
You mentioned the signing up for Affordable Care Act.
Mm-hmm.
Now, I've been seeing something in the newspaper about allegedly 40,000 people signed up for the connector, and yet today I see only 12,000 people signed up for the Affordable Care Act. Now, what's being done to transition these allegedly 40,000 into the Affordable Care Act?
I think the alleged 40,000 was actually 16,000, and so we are well on our way to, we have approximately 15,000 signed up today. And so we are very close to at least meeting that goal. What's being done and what has been done is that the two issuers, which are HMSA and Kaiser, have contacted all of their current members on repeated occasions through mailings, through phone calls, through on multiple occasions, and they're doing so again this week. The state with the Hawaii Health Connector, they started the process, and now the state took over in December. We also have an outreach team. We have approximately 20 organizations that we work with who have hired about 120 Kokua sisters. They are all on all the various islands. We've been reaching out and doing outreach events in several targeted ways. One, we've been having a series of outreach events. There's a calendar that's posted, continues to be posted on the Hawaii Health Connector's website, which is still active. We also have a list of all the Kokua and their sort of office hours and when they're available, so that you can stop by anytime and meet with them, or call them, make an appointment, or call them and have them help you on the phone do the application at the same time. We so that there, and then we've also been doing, there's also been some mass mailings to all the individuals who we are aware of as well. Our effort is to target the hard to reach populations, or the harder to reach populations, those who may not speak English as a first language, those who are homeless, who might not have a steady address, the lower income individuals. So we're doing a lot of effort to try to reach the populations that are harder to reach. And in Hawaii, if you're thinking about it, because we've had prepaid for the 40 years, the number of uninsured we have is actually quite low. So we sort of like only have the most the individuals who have are the most challenged, or have the most challenges in signing up for insurance left to try to reach. So it takes a lot of work and a lot of effort to try to reach out. But the numbers that came to us that were published as of the end of October of 2015 were in the 16,000 range. Yeah.
One more. You mentioned funding doctors to take care of us when we're sick. Now, how does one go about funding doctors for preventive care to keep us healthy?
There's a number of different efforts that are going on right now to try to sort of redo those financial payments. One such effort is to essentially pay a certain amount to a primary care provider, for example, for every person who is under their care. So it's a set amount, and it takes into consideration both those individuals who don't need very much. So they just might need to come in for an annual, immunization or an annual checkup, and those individuals who are going to need a lot more care because they might have a chronic condition of some sort. And so what's being looked at right now and what's being tested right now are different sort of payment models that take into consideration, okay, here's how much, we think that it would take for you to take care of sort of like this average person, and then you're going to have the curves on either side of some people who need a lot less and some people who need a lot more, and then look for that balance. And then to add in extra pay for accomplishing certain outcomes. For example, they meet certain quality metrics, or they participate in a certain amount of continuing education, or they sign up with a health information exchange so that they can get their lab data electronically, no matter who's providing it. So there's ways right now that people are looking at on how to sort of restructure the payments for at least the primary care providers. It gets a lot more complicated for specialists, but an example of what's being looked at for specialists now that is going on in a couple of different states that I'm aware of is they're looking at what's called bundled episodes of payment. So taking something like hip replacement or knee replacement and looking at, first they're looking at what the quality metrics are to make sure that the people who have the least number of costs are still providing quality care. They're still meeting a certain basic good care for those procedures. But then looking at what's called the total cost of care, so it's not just whatever that provider was charging for the hip replacement. It's also looking at the hospital costs. It's looking at any, X-ray costs, or the anesthesiologist or the referrals. So it's looking at the total cost of care, and then putting all those providers on a sort of continuum. And for those who are performing well, in other words, they're not performing inadequate care, but their total cost of care is saving, that's pretty low. Then you have the middle, and then you have those that are costing the most. And so what's happening now is that if you're on this end of it, on this end of the scale of being the lower cost, then you get bonus dollars, you get some of the shared savings from that. If you're in the middle, then you get no change. And if you're on the lower end of it, then you get penalized because you're providing care and your total cost of care is way up here. Where that's happening, what's going on right now is that one, providers are getting information that they've never had before. Because normally they know what they charge, but they don't know necessarily what's going on with all the other with all the other providers because we have a very siloed healthcare system. And so for those providers who are on the high end of it, they're starting to realize that, oh, I'm using this particular provider and they're charging twice as much as anybody else in this whole area, and I could use this other person over here, and that would bring the overall total cost of care. What the impact is that overall, you're going to start seeing the overall total cost of care start to come down. It's just a different way of starting to take a look at how do you pay for this, for the healthcare system in whole. How do you pay for it differently?
About a year ago, before you came, I was helping a family member sign up for Medicaid. This person wanted to sign up for Kaiser. They were getting notices, official notices that says, you cannot sign up for Kaiser because Kaiser is no longer taking Medicaid. This was on for 6 months. Notification from Kaiser to DHS, back and forth, only by having a friend in the Kaiser world could this be cleared up, right? This speaks to an administrative snarl, which sounds like it's still going on between 40,000, 16,000 and whatnot. And many of your ideas sounds like a lot more administrative rules and sorting out. How,
Hopefully it's a reduction of it.
Where are we in this administrative nightmare?
That's one of the big costs of the overall healthcare system. It's one of the drivers of the healthcare costs is the administrative burden, right? And it's, all the paperwork, it's all the forms, et cetera. And what you're talking about is regarding the eligibility and enrollment. And yes, we definitely have rooms for lots of room for improvement in there. And I will say that in the last year, there have been a number of changes that have taken place to make the eligibility system easier to use. That still doesn't necessarily impact the specific question or the specific issue that you brought up regarding the enrollment, because I happen to know that we still have that kind of gap in the actual enrollment, in that we don't include in the application process the provider choice. So, and then Kaiser winds up being close to new enrollment, and that was what makes it challenging when people want to sign up with them. Then they were closed for a period of time to any new enrollment, and so hence everybody wound up going to one of the other plans. Well, there I can't help you because I have no idea why they would have been closed at that time. I mean, why they were open. I was told that they had been, closed for a period of time, and that's what our system was. So it's likely that you're exactly right. That kind of, the more administratively complex things are, the more things can go awry, right? So your other question is, well, how can you implement any of this in a way that doesn't just create more administrative complexity and more administrative entanglements? And that's actually, what I will tell you is that today we can't. Today we do not have the infrastructure, we do not have the IT or administrative infrastructure to help that happen. But it is within sight and it is within grasp. And it does rely on a really mature health information exchange, which means that clinical data can be accessed by the required providers so that they understand and have access to all the care that a person is getting, even if it's not from their specific office. So that they know all the medications, for example, that someone's on, and they're not either duplicating those medications or prescribing something that would be have harmful effects if taken with that other medication. So it's that kind of a thing where that's actually under development right now. We have a Hawaii Health Information Exchange, which has nothing to do with the Hawaii Health Connector. It's completely different entity that's focused on, and it's a multi-payer effort, multi-provider effort. So it's not like a Medicaid thing. It's actually, all the various health insurers, health systems like Queens or Hawaii Pacific Health participating in this information exchange. So once you have that kind of a more mature system, then you're much more able to it gives you the foundation to be able to take on some of these payment reforms. The other thing you also need is pretty substantive and substantial data analytics. That also is sort of lacking. The expertise, et cetera, is not necessarily in-house. And in a smaller state like ours, it is more challenging sometimes to get that expertise. Again, not an impossibility, within sight, within grasp, but today that is something that would also have to be put into place in order to have some of these other ideas happen. And we're not there yet.
Hi, so you were talking about some policies to promote health, aging in the home, right? And you mentioned one policy. Well, can you name some of the specific policies that do that? So you mentioned the one that, like, for the at-risk, those at risk. And then also for a given policy, for example, that policy for at-risk of going into nursing homes. Can you talk about, do you have any, like in Oregon, do you guys do any projected economic impact? Like you're expanding eligibility, so it should cost more, but does that save by delaying entry into nursing homes?
Okay, so the Medicaid expansion is usually the people that it's targeting are those people who have been traditionally uninsured. So so it's less about delaying time into or need for nursing facility care or home and community-based care. So in the long run, you'd be right, but in the short term, it's more around that acute care side than it is on the long-term care side. So I'm actually going to put that question aside and talk a little bit more about the specific policies having to do. And I couldn't quite hear about what. So I'm guessing you were asking me about home and community-based services. Yes? Okay. So I think where we're talking about making some changes in policies are more targeted on the behavioral health side, because the behavioral health services are pretty for a pretty narrow population, and the services that we have available are also pretty narrow. And what we're looking at is in what ways can we expand those, because if we want to make a difference with one aspect of the homelessness issue, homelessness crisis in our state, that is an area where Medicaid can make a substantial difference. Our limitations within the Medicaid program are that those kind of supports and those kind of changes are for a disabled population or an at-risk disabled population. So currently, the way that we have our policy set up, again, are on a pretty narrow frame, saying, you have to have this diagnosis, and it needs to be these two diagnoses. You need to be sick for this long, with these kinds of things in order to qualify for these services. And what that does, of course, is it does narrow the resources. I mean, it does narrow the population who can get those resources, but have we made the gate or the door so small that it's actually preventing people from needing that level of service, or if they drop below needing that level of service, do we have the other community supports that would keep them from needing that really high level acuity care. So one of the things that we're looking at right now, and it's pretty recent, because the federal government just came out with clarifications just this past year on how we can expand our housing supports. Is what we're looking at is we're going through our list of each of the services within that area that we provide, that we have access to, what the population is, what the criteria is, and then whether the Department of Health pays for it also, or whether just MedQuest pays for it, and then what we're doing is looking at the list that came to us from CMS that said, hey, you might want to think about expanding your policies and your policies around housing in order to better support homelessness by considering these things, considering changing your population or changing your services that you provide in these ways. So we've added to our matrix of saying, okay, we provide these services. Okay, so is there a broader population that we could provide to, and what would that mean? And then, are there services on that list that we got from CMS that we are not covering today that we could? So I know that was probably a little bit long, but and I don't have any. I'm trying to think of specifically off the top of my head some examples, and it's not coming to me, so I apologize for that. But that's an example of what we're doing, and we're doing that with Department of Health, with the governor's homelessness office, with anybody who's working on that particular topic.
So I have a question over here.
Sorry. Yes.
So the income limits to qualify for Medicaid are what again?
Well, it depends on the population. They are 133% plus 5 for able-bodied adults, so 19 through 64, just under 65. They are up to 300% for children.
300% of what?
A federal poverty level.
Oh, okay. So how much is that per month?
Let's see. I'm thinking that per year. I should have this memorized. Rachel just did this last week, and I was going, oh man, I gotta memorize this. For a single person, the federal poverty level, I believe, is $12,000 per year, something in there. It's pretty low
Okay.
income, but I can get that for you because
So
I don't
if
have it off the
you're-
top of my head.
So if you make under about $15,000 a year, then you would qualify. And
You can qualify for Medicaid.
You can qualify. And your monthly expenses are deducted from that, right? So that's disposable income or total income?
So if you are needing long-term supports and services, that is a whole other range of income and asset tests. If you need long-term care, if you're either elderly or disabled, then the income limits are based on what Social Security income limits are. So if you do not need long-term care, then it is 100% of the federal poverty level, or 100% of the Social Security income, which is about 65% of the federal poverty level. If you do need long-term,
That's for supplemental income. Okay.
Mhm. If you do need long-term supports and services, it's 250% of the federal poverty level, which is about 300% of SSI. And there is an asset test, and I don't know what it is.
That's for
Off the top of my
long-term
head.
care.
Mhm.
But for other care, not long-term, there's no asset limit.
If you are able-bodied, if you are a child, if you're an adult under the age of 64, there is no asset test. If you are over the age of 65 or disabled, there is an asset test.
And what is the?
I don't
You
off the
don't know
top
what
of my
it is.
head. I didn't memorize that before I came.
A lot of people don't know that there's not an asset test.
For
in fact, we had
for able-bodied individuals.
Yeah, for
Right.
anybody. In fact, we had a social worker here who worked for the county a couple months ago who whose job it was to steer people towards medical care, and she did not know that. So
There is an asset test. There is an asset test if you are disabled or if you are over the income. If you are a child or able-bodied adult, there is no asset test.
You really sound like a public health person.
Thank you. I'll take that as a compliment.
It definitely is a compliment. We've spent years trying to look at the integration and the relationship between health and social services, which you cannot separate, and we have done.
You cannot
You
separate.
cannot separate it. So now we're reintegrating. I'm glad to hear that. I have a couple of things. One, you were talking about the interface of programs, and I'm very concerned about the Kokua Care program, which is a state-funded program for those above the poverty level.
Mm-hmm.
And where we've run into issues in the past is where that overlap might occur. When we set that program up, we wanted to have people in our program that weren't covered by other, financial services, because we have a tiny bit of money. And, we usually only can give 1 or 2 services per person out of the 8 that we offer. So it's a very, very scarce program.
Mm-hmm.
So our rules said that if you're on Medicaid, you're not eligible for our program. And yet there are some instances where our rules might be a little bit more liberal than the Medicaid. And,
Or they might be able to pay for some services that we can't.
right,
Mhm.
and that plays out and actually causes us to not be able to serve somebody else.
Mm-hmm.
One of them was the discrepancy in case management, whereas we were providing more of the social aspects and as well as the health care. Some of our providers were also providing to Medicaid, and it was pretty strictly health. And so they wanted that health care case management plus hours at the same time.
Right.
So we were objecting. And the other one was on meals. We had a little more liberal. You don't have to be just strictly housebound to get some of our meals because you still have needs. So I think that Patty was, addressing that, and particularly in Maui, where Maui County was aggressive in going back and saying, would you please reassess your people to see if their eligibility can't be expanded a bit. And I just wondered, is that continuing with the other counties as well?
I would have to get back with you on that. I simply don't know
Okay.
on that
We would love
particular
to work
element.
with you on that because
Yeah.
I think there's a win-win situation, and Patty certainly had those ideas. But
That'd
it
be
has
great.
a major impact on our program.
Right. And you know that Patty, she took a different position, right, last October, and
Yeah.
we're still in the final stages of hiring. I hope to have somebody
Okay.
new aboard shortly.
The other thing quickly is the transition. The transition you were talking about from one place to another, and that goes with Tony's question. We were told that maybe CMS is going to have some new rules and regulations that would require more instruction in the hospital, because we're not seeing personally from a community standpoint, from a personal standpoint, that they're getting the people in the hospital before somebody's discharged gets the instruction they need and does not have a designated caretaker. I can give you many examples of my own family in other states where they're going home with nothing, and they're not getting anybody into the home for several days with a critically ill person that an 85-year-old has to take care of.
Mhm.
So that is our big concern, particularly with this caregiver bill.
Yeah, I would have to check because I don't know, I don't recall having seen any recent rules coming down on either Medicare or Medicaid. So I don't know.
And it would only affect those in Medicaid, so we were concerned about
Yeah.
that.
Let's give her a round of applause.
Thank
Great,
you.
great answer.